A little bit of what we're going to be talking about. I think you can all um, appreciate this, but if you are an outpatient therapist, we'll start with you. If you have the privilege of working with doulas or birth support individuals, they're a great referral source. And I really want to kind of frame this conversation of starting a rehab program on the maternity unit of a hospital. If you're coming from the outpatient setting, which I've found myself working a lot now, I find that doulas are probably the single most important partners or professionals that you could partner with. And so my story starts in 2020 when I started a new position to me. I was completely green in acute care. I had seen maybe a few patients here and there um, when I did rounds in the inpatient unit at Duke during my women's health residency. But after that, I was an outpatient therapist from 2016 to about 2019. And in 2020, I found an old lecture from physical therapy school where we had one day on pregnancy and postpartum, probably a half a day, if I'm going to be honest. And there was one slide that mentioned this doula that specialized in high risk pregnancy. And I pulled up this one slide from PT school, which was now about 5 years ago at that point. I had graduated in 2015, so it was several years ago. And I found this one slide, and her name was Darlene Turner. And so Darlene Turner was a doula that practiced in Austin, Texas, but I knew she did courses to providers on high-risk pregnancy and treating the patient in the antepartum unit. Now, mind you, I was a physical therapist. I had went through a residency at Duke University in women's health. After my doctorate of physical therapy, I had gotten my board certification as a women's clinical specialist. I had done a few rounds on acute care. Mostly it was the antepartum unit, if we were called, for those individuals who needed to be checked out before they went home. And then also, I really mainly worked in outpatient oncology. So I would work with those individuals and see a lot of people, a lot of women after a mastectomy or after a hysterectomy. And I really got burnt out within my first 2 years of physical therapy practice. I didn't really want to treat lymphedema or chronic pelvic pain or urinary incontinence and a lot of complex pelvic issues when I knew I could do something on the front end, which was see those individuals within 2 to 3 weeks after surgery. So I really switched my practice more to kind of an outpatient ortho. I wanted to see a lot of post-op referrals after mastectomy, after hysterectomy, and I even started in inpatient acute care with that hunger as well. I really loved seeing individuals after surgery because I felt like working upstream could mitigate a lot of those complex issues I was seeing as a pelvic health therapist. And so I met Darlene online. I found her number off her website. All of this is coming off of a PowerPoint from PT school. And I called her Darlene and I said, I just took this job in Houston, Texas as a inpatient women's health therapist. I have no idea what I'm doing. I never worked with people who were pregnant on a high risk pregnancy unit, and I never worked with anyone within 2 or 3 days after birth. Like, what do I do? And I paid her $125 an hour. It was a 750 course where we met over 6 weeks. We sat down 6 times for 1 hour, and she went over everything. It blew my mind. I never, even after all of that training, got so much of an in-depth look from a dualist perspective about the experience that people had being in the hospital during their high-risk pregnancy stay. She was giving me research that I just wasn't exposed to at that point. Research on the ineffectiveness about bed rest. There's nothing in the literature that supports having the recommendations that someone should be on bed rest to prevent a preterm labor. And yet, within weeks of taking kind of that one-on-one course with her, I was starting on a unit where I saw bed rest all the time, where I saw women who were afraid to do anything more than use the bedpan or even a bedside commode because they thought their baby would fall out. And so that all happened in the early parts of 2020 before the pandemic. And when the pandemic hit, this is where my story gets a little bit interesting and why I want to bring up the therapist that I think really kind of rounds out the experience for me. And so I'll bring up Dr. Bradford in a second, but I want you all to understand is that when COVID hit, births didn't stop. So I was suddenly faced with a team that was warm, open arms, welcoming physical therapy kind of on the team to really kind of start seeing more patients, whether it was antepartum, whether it was gynecological surgeries like hysterectomies, and even some postpartum. We were at that time seeing a lot of cesarean hysterectomies, and we went all in the other direction of you really don't need to work. We don't want you to stay home. If you need hours, you could do temperature checks for the staff coming into the hospital. But other than that, we're stopping the program. We don't really have work for you. And so I had to justify in the middle of the pandemic why our services were important. And that's really what I want to kind of start the conversation with you all today as to why, even in kind of the most extreme cases, why you can still justify your services as a rehab professional or even use your partners, and we'll talk about who those are, to bring your services to this population. Because I think for me starting in the pandemic and starting around COVID, I think I got to see a real clear picture as to why we needed to be on the team as providers, from helping people to walk for the first time after a major surgery or after being intubated, after severe blood loss, after having issues with just a kind of daily activity that we would really take for granted, taking a hot shower. Many people have heard me say this, but taking a hot shower when you've lost a lot of blood um, causes such an energy demand on your system to where you could actually strain uh, organ systems and processes from working and functioning. And so when you think about diagnoses like preeclampsia, you're really thinking of a diagnosis that's a journey. It's a journey to get there. There's so much strain that has to happen on the system, on the circulatory system, on the organs, to where it's really not just a one-time event. Preeclampsia is really a lot of smaller events that lead up to that. And so I was seeing individuals after a huge surgery, cesarean hysterectomy, C-section, trying to shower, and I knew that they would not be able to do that without actually sitting down or conserving their energy. But we didn't have an occupational therapist on the team. We didn't have anyone who could order DME. A lot of their insurances didn't cover that DME very early during their postpartum stay. And so I had a lot of barriers I had to navigate in the middle of the pandemic. So let's actually go through the vehicles that I usually will suggest that people start with when they're starting a program. And I like to really give you an idea of how important it is to think of your team as vehicles, especially if you're operating outside of the hospital system, which I am now. So, vehicles are kind of the way that you get your services into the hospital. The vehicles can be people. I started out my story with Darlene Turner, who is a doula. Yes, I had been all through the coursework that you can imagine, including lymphedema certification to get there, but I didn't really have a vehicle that got me into the hospital other than a job. I had a job posting and I was really lucky that I was able to actually get in before the pandemic. But otherwise, I would not have been able to offer my services on the maternity unit other than having that job, then other than having kind of the framework that Darlene Turner set for me. And she was a physician's assistant by background. We actually went through to the same hospital system. She practiced at Duke in North Carolina, and I did my residency at Duke. And we really connected on this idea that, well, if PT or OT isn't offered in the hospital, is there a vehicle or is there a person that could bring those services in? So I really got interested in Darlene being that vehicle for me to introduce me to this world of doulas that I really didn't work with before. I did not work with any doulas until I started seeing them more and more in the hospital and started to develop a network. And so your vehicle, if you are an outside provider, may be that you put your OT or your PT hat aside and you start to form relationships with doulas in your community. And so for those of you who already answered this, I want to see in the chat again if you can put if you've worked with a doula, have you ever had the opportunity to work with moms either during high risk pregnancy or immediately postpartum after being referred by a doula? Put in the chat if you've worked with moms either during high risk pregnancy or immediately postpartum by way of a doula. You've received this referral. Perhaps you were in the hospital and maybe it was an outside referral, or perhaps you were in the community and perhaps that person was able to be that vehicle that brought you into the hospital. Put in the chat if that's been your experience. Fast forward to 2022, that was my experience. I moved since then from Texas and I moved to Colorado, and I actually started to create a lot of relationships outside of the hospital, and doulas were my go to. So, not only did I start my career in this arena as a pelvic health therapist working in the hospital with individuals after C section, hysterectomy, a traumatic birth, third and fourth degree tears, I actually started my outpatient practice still working with doulas and having them be the vehicle that brought me into the hospital where I could actually treat as an outside provider a person in the hospital after birth. So the second person that you want to think of is your champion. When you're thinking of starting a rehab program, right, on the maternity unit, you need a vehicle to get you there. That vehicle could be a person. I really strongly suggest always partnering with birth providers who are independent providers. They're able to collect their patients, if you will, outside the system before they're coming into the system, and they're invited into the hospital. So they don't work for the hospital, they work for the patient. And so I really have been trying to train providers, not who only just work for their hospital, to retrain their thinking of not just working for their hospital, but actually working for their patients. And that's where we'll kind of get into the conversation with Dr. Bradford, which I'm really excited about. So the second person that you want to use, if you don't have a vehicle of a doula, it would be that physician champion. It would be someone who's championing your efforts once you're in the hospital, or someone who knows your work in the community. And I mean, ideally, it would be someone who's already on the team. And my champion at this point was Dr. Fox. Dr. Karen Fox was a physician at the hospital that I worked at. And I remember one conversation I had. I was kind of in a funk. I had treated my second patient of three. The third one hadn't arrived yet, but it was a second patient who was readmitted to the hospital after a cesarean section had opened and separated. And this individual, like the three women that I later did a presentation on, this individual had a primary C-section. It was their first surgery, no C-section, no birth before. So they had really no experience of healing after a major abdominal surgery. And I call Dr. Fox and I say, I'm really in a pickle. I do not have kind of the background of how major this surgery is. Do you think we can just talk about what I'm seeing? And she was absolutely like amazing to talk to over the phone. So I talked to her about what I was seeing, and I was seeing women who were upright, individuals who were upright in bed right when I walked in the room, which was the second or third day after surgery. And they were just folded right over their incision. A lot of them hadn't even looked at their incision. It was wet and moist. And I did a lot of just explaining how in the ortho world, we would never see someone after a knee replacement just resting over the pillow. When I said that, the conversation immediately changed. I didn't go at it, and this was in June by this point. So I was kind of also fighting to keep my position in the hospital and not do temperature checks for COVID. I was really trying to fight to see this patient population because I'd already been seeing people coming in to the hospital being readmitted after cesarean section infection, and also for COVID, and also for high risk pregnancy. But this was really kind of like the kicker, I would say, as to where I started to reach out for my other teams and where I started to develop this relationship with this physician champion. And so what I explained was, I really think what's going on is the incision is separating because of just the amount of weight and stress and fluid that's just in that area. And that's when the conversation changed. We actually started having a dialogue about what I was doing to mitigate that, I was having individuals lie flat, and how she actually wanted to make it into a protocol. She said, "Okay, I want everyone to lie flat for 10 minutes, an hour." And I said, "Dr. Fox, that's totally unreasonable. These are women who just gave birth. They're going to be breastfeeding. No one's going to do that 10 minutes for an hour." But if you see kind of the theme here is that we were working together to solve a problem that I identified after I had treated so many people, and a problem that she very much wanted to solve at being the surgeon, right? She didn't want complications on her surgery. And so the second kind of point I want to make for you all is that if you have somebody who could bring you into the hospital, great, but you need someone to keep you in the hospital. And had I not gone about even building our program in that time frame, I wasn't actually thinking of building a program. I was just thinking of providing a service and solving a problem. But I was really trying to solve little problems along the way, and I was asking for help and asking for input. What I see a lot of therapists when they're messaging me, "I want to start this program. How do I pitch?" And I'm like, "Have you even spent time creating relationships? Have you spent time talking about things that you're seeing and you're not really sure if it's adding up and you'd like some help? Have you even spent time asking a surgeon, can you observe their surgery so you can actually see all the layers of a C-section and all of the force that's put through the abdominal wall? If you haven't, your first go is not to pitch. People want to be engaged. We're human beings. We really like each other. And so if you haven't spent time just getting to know someone and picking their brain and giving kind of the value back to them, that you value their opinion, you value where they've been, and you just want to have a conversation, pitching is not your first go with this population. And so, vehicle, it could be your doula, it could be the person, it could be actually reaching out to your patients. You might see that a lot of therapists are already putting themselves out on social media because the secret is not out anymore. I mean, it's out really. There is no secret. Social media is not social media anymore. It is social marketing. It is a free space where you could put your ideas out into the world. And so, though I didn't have a protocol, that lying flat after C-section was a really great way to heal and recover after a major abdominal surgery. This surgeon was willing to jump on it. And so that gave me kind of the you will, at the end of 2020 to write my first commentary, which a lot of people have poo-pooed and said, "Hey, that's not real research." Well, hey, do you see anything else out there on this subject of physical therapy in the hospital after C-section? No, you don't. So that's the first step to research. So that was my vehicle, whether it was putting things out on the internet, writing for journals, making YouTube videos, or working with people in the community like doulas. That was my vehicle into the hospital. Doesn't really happen any other way. If you're an outside provider, you need a vehicle that brings you into the hospital. And if you create something online that your patients can see beforehand, and then you can create maybe a virtual telehealth service that they can connect with you while they're still in the hospital, that's your vehicle. You're using a tool to get into the hospital. The second is keeping you in the hospital, your physician champion, your surgeon, maybe your nurse, maybe the pediatrician. But then once they're a champion, they have to tell other people because eventually you're going to have to embed yourself onto the team, and your team is going to be your network. And so before I bring Dr. Bradford up, I want to end with who that network could possibly be for you, especially if you're an outside provider, because that's really where I'm focusing now. I spent the first 3 years of kind of this journey for me really focused on acute care therapists. And I love that there's so many of you here today who are working in the hospital who want to build either your program or expand your services to include more than just people after C-section. You want to include those after vaginal delivery who might have lost a lot of blood. You want to include someone who has tailbone pain or has pubic symphysis pain and can't walk. You want to include the individual who's having shoulder pain or neck pain. And is it from preeclampsia? Is it from positioning? You just want to make sure that those individuals are also taken care of before they go home. And so I spent a lot of time with you as an acute care therapist to build and start those programs. But now, how about those therapists that are in the community where their hospitals are not allowing rehab on the maternity unit. They're not supportive of these programs. They think that your services are pretty redundant. Nurses are doing them just fine. Patients are up and walking fine. You're really not needed. How about when you have those individuals who go home and now they have complications because they didn't receive the same support that they probably would have benefited from when they were in the hospital? And so that's where your network comes into play. If you're an outside provider, this is where you would start. You would start with a doula. You would start with a vehicle that's some way, somehow allowing you to have contact with that person while they're still pregnant. You would then have some type of champion, someone to keep you there, right? To advocate that, hey, I really notice what Marley is doing. She's an occupational therapist that works in a level one trauma center. And I really think that she would be a great asset to our team if she were to stay on and see this patient population. Or maybe Marley has a colleague out in the community who does telehealth services. And maybe that person who's doing telehealth or virtual services could actually connect with that person while they're still in the hospital and right when they're returning home so that they can give them a call just so that they're checking their blood pressure, they're checking their vital signs, they're not overdoing it with their children at home. And so that's where a network comes into play. You'll need that in or outside the hospital. My network happened to be a pediatrician, lactation consultant, and several nurses that I really formed just a relationship with. Again, a lot of this starts with relationships. I was not coming in with these great grand ideas. I didn't have any. It was in the middle of COVID. I was watching and just observing what was maternity care like in the hospital. And boy, did I have wake up calls over and over and over again. However, I allowed these individuals, each of these individuals, pediatrician, IBCLC, as a lactation consultant and an obstetric nurse, to observe my practice in the room. This was really, really important. So even if you're an outside provider or whether you're an inside provider, if you have the option of having someone be in the room when you're treating, that's probably the best way to sell your services. You're essentially selling your services to the hospital, to the person, to the patient, and also to the team. And so if you have someone who can shadow you, pediatrician, it was easy. They were always evaluating the baby when I was with the mom. IBCLC, that was amazing and actually ended up being amazing for my outpatient practice. When I was getting the most referrals, it was from a lactation consultant, and that allowed me to see moms within the first 5 days of birth. So an IBCLC or a lactation consultant is going to be someone who, if that person had a C-section, is going to try to be creatively thinking of ways that they could actually help that person stay with their goals of breastfeeding. After a C-section, it's a little bit harder because of a lot more healing involved and energy that it takes to breastfeed. And so to work with them as an occupational therapist or a physical therapist, that was a game changer. And then, of course, OB nursing. Some of you have already messaged and responded to a call out that I had just a day ago about some of the challenges that you're experiencing with growing your program. And it's been with nursing. And not all nurses are the same. They're very, very different. The culture is very, very, very unique. They like to feel that they're competent. They have a very high expectation that they can manage their patients, their caseload. And keep in mind, they have two patients. They have the baby and they have the mom. And they have several couplets like that if you're dealing with this population more so on the postpartum side. And so anything that you say or do is a reflection of how they view your assessment of their performance, if that makes sense. So you're not doing their job, and you can only form a relationship over time to explain that and to show that. But you really have to seed in that you're there to help, and that relationship is going to take time. And so with nursing, especially, it took a lot of time for me. It wasn't until November of 2020 that I really thought I really broke through with a nurse. And she was the one who actually encouraged me to get the patient's story that she was actually observing me. She was observing me with this woman after C-section. She encouraged me to contact the marketing department of our hospital and get her published, saying and testimonial, giving a testimonial about her experience with physical therapy. I would not have done that had the nurse not seen and valued what she was seeing in that treatment session and telling me, you have to get this around the hospital. Not everyone knows what you're doing. I didn't even realize what you were doing until I saw you. So please, if you're in the hospital or out of the hospital, your network is so dependent on you embedding your services on that team. And that's where I want to call up Dr. Bradford. I would love to speak with you about your experience as an acute care physical therapist, as well as an outpatient pelvic health therapist. Just with your team, I want to start there. I want to start with the team that you've actually been working with and have created. Who's been on your team?
Well, at the moment, everybody, so we finally got the new PT. She finally came this week. So I was like, yay. And then our other PT who's going to be new, I believe she starts next week. She used to be a student at our hospital. And then after nagging her multiple times, I convinced her to sign on. And so,
You have
um,
a student that
hmm?
was a student, and now
She
you
was a
convinced
student.
her
Uh-huh. It
to
was
sign
me
up.
and the other full-time therapist. We were like, there's a bonus, right? And you just got engaged. That's extra money. So she finally caved, and so she'll at least be here for like a year or two. And
That's
she's gonna
awesome.
float and do in and out like me. Because she wants to keep up with both skills. She doesn't want to lose her outpatient skills.
All right, so
So
let's back up. When did you start your program?
so I started the program uh in October of last year. Um, that is when I made my pitch for the inpatient rehab. Um, just because, as a new mom myself and having my own traumatic birthing experience, and then just knowing lots of close friends and former basketball teammates and girls that I played in like different leagues in when I lived in LA, just hearing a lot of their stories, I was just like, wow, we really don't have the best support. And I wanted to change that. So thankfully, I have a very, very open minded boss who was just like, yeah, sure, do whatever you want. She was like, who do you need? Who do you need to talk to? I'll give you all the connects. And so if it wasn't for my boss, who was just super open to everything, because she was the one who gave me the information to the labor and delivery director, she also gave me one of the head nurses, and then there was another person. Oh, the nurse practitioner who's upstairs gave me like their contact information so that I could actually start by just pitching the idea in one of their OB meetings that they have like every twice a month.
Okay, so back up because that was a lot. So
I know.
you
Sorry.
okay, so you had a wonderful boss. Did
Mhm.
you know coming into that hospital that that's what you wanted to do, or were you working already general acute care?
So I knew I wanted to do pelvic health um, since once I started this job. And whenever she interviewed me, I had asked her if they had a program just for outpatient. And she said that they didn't, and she would be open to having like starting one. And then so I was like, oh, cool. So what about inpatient? Are you open to that as well? She was like, whatever you want to do, just tell me issues. After I explained kind of like how I thought it would be beneficial, because I had saw you on YouTube and one of your interviews, and I was like, that's genius, we definitely need that in acute care. So I just literally verbatim just told her what it would be about, and she was open to both right from the get-go. And
Right from the
so
get-go.
and I didn't
Okay.
like, I just started this job late June of 2022. And then in October was when I made my pitch, because I was like, okay, cool. These people see my face. They know who I am. They've at least seen how I work and like interact with patients. So I'm like, okay, cool.
Okay,
This is
Keisha, I have
enough
I have a few
rapport.
questions. You said late June, and then you made your pitch in October. What did you do? What did you do between June and October?
I worked in acute care only. I was just in the inpatient. So I saw, you know, ICU, PACU, PCU, med tele, just your general, like everybody.
Mhm.
Um, and then after, because I was a traveler, I had signed on as a traveler because I wasn't sure if I was going to like the job. And then once I was like, oh, I like this place, I don't mind signing on full time for
Mhm.
however long I'm here. And then that's when I was just like, so remember during my interview when I told you that I probably want to start a pelvic health program? And she was like, yeah. I was like, can we start it? And so then we literally just was like, she was like, okay, well, give me a date, tell me all the things you'll need for outpatient. We got to figure out a room. So she was more so focused on like the outpatient. And then I
Uh-huh.
was like, but don't forget about inpatient. I want to see moms right after they have their babies
Now
as
this is
well.
unusual because this actually goes against with what I recently told someone. So did
Yeah.
you see anyone in inpatient before your pitch?
Mm-mm.
You
I
just had your
honestly,
birth experience.
yep. And hearing other friends and like former teammates and hearing their experience, and even asking, because before I even made the pitch to my boss, I had even brought up the topic to like my coworkers. It was just like, I really feel like we should see these moms more often, like especially after surgery. And literally three of my coworkers have had C-sections, and two of the three had very traumatic birthing experiences, to where even to this day they still have some sort of pain, like pelvic floor dysfunction. And I'm just like, wait, what? And
A
so
and Doctor Bradford,
they,
you actually shared your birth experience. You don't have to share all of it, but would you just kind of remind, like, me of how that played into you wanting to treat this population?
oh yeah. So let's see. I had my son in September of 2022. And then um I wanted a completely natural birth. I didn't want any kind of medication, nothing. Scare tactics were used to get me to say yes to Pitocin, even though I did not want anything. So just because scare tactics were used, and obviously I'm not in the right mindset, I was just like, sure, fine, whatever. I'll say yes to Pitocin. Ended up having the vaginal delivery, severe amount of pain, to the point where I was in so much pain, I was in sideline, and the nurse literally took my arm and forced me into supine, and then had my friend grab my hand so that I would stay in supine. And then as I was pushing, I had a grade 2 tear. And then as he was stitching me, like he injected me with whatever numbing agent, but he didn't even wait. He just started stitching, and I felt everything. I felt like the first three. And so my friend had to actually like get in his face and was like, "Can you stop? Can you not see that she's in pain?" And so then he like poked me and was just like, "Do you feel this?" Did it 3 times. And I was just like, "Yes, this feels like sharp stabbing pain." And so then after that, he injected me again, then waited, and then finished stitching me up. And then that was fine. But then just even the whole experience of kind of knowing how, like, as a PT for acute care, you know that the biggest thing is you want to work on like mobility. And I, at the time, I lived in a 2-story home. Not one person even made sure that I could actually go up and down the stairs. And I was just kind of like, hmm. So y'all are just gonna base on the fact that I can like walk down the hall and back, that I'm good. So that, all of those little things. And then even once I got home, when you were talking about like showering being extremely taxing, oh my goodness, as you can see, I have a lot of like curly hair. So that, it was just a lot. It was just the hot water, like to the point to where I was like hovering over, and I was just like, my God, I feel like I just ran like a whole bunch of sprints, like I'm playing basketball, like why I'm exhausted. And so, yeah, just the limited amount of care, and then a lot of people just making assumptions because I was an athlete, that they're just like, "Ah, she's fine. Ah, she's fine. She's okay."
Keisha, were you walking, like,
Mhm,
within the first day? So you were
mhm,
walking.
mhm.
And have you heard of the term, I seriously had to learn this, but walkie-talkie?
No.
You've never heard of that?
No.
Wow, you're so lucky. When I heard it, I wanted to throw up. So it's apparently this term that some people will use to describe patients in the hospital who are already walking and who are already talking. And
Oh,
so they didn't
wow.
really need therapy,
Wow.
right? And so exactly. And so I get first of all that concept when you're in a level 1 trauma center and you see the worst of the worst and all of that, right?
Mhm,
What I would love for those therapists to just think about is making room for providers who can treat that patient population the way that they would want to be treated, not the way that you think they want to be treated.
mhm,
And so I was like obsessed with this after your story. I honestly, I had you tell me that again, just to share and just to reiterate that you pitched, but you didn't pitch cold. You pitched from your own experience.
mhm.
You pitched from your friend's experience. You're an athlete. You're a basketball player. I've heard you're actually pretty tall. I can't wait to meet you in person. But like just to like
Yeah.
because I've heard and I could just I have that sense. I also
Whole
have a short person.
6'1".
So I'm like, yeah, you're 6'1",
Yeah.
right? And to have to hold your wrist down and have to go through that within a year of your birth, you were already preparing to pitch to physicians, to OBGYNs, which
Mhm,
to me, if I was having to face another OBGYN after that experience, I wouldn't be the same person. So you've been kind of an anomaly ever since I heard your story and then realized when I read your text, you got the program up and running within how long after that pitch?
2 days.
2 days.
Yeah.
For
I had
better
my
or for
first
worse.
eval.
Right? For better or for worse. So my question to you is here's the question I want to answer before I open it up to the audience, because I want to bring up some people. For people who are encountering individuals like you already up and walking, and they're being told there is no way these people need your services. One is going to be redundant billing, because first of all, we don't need OT and PT, right, in the room,
Yeah.
right? And also, it's just also going to be just a waste of resources. We need you on other units where patients are not walking and not talking.
Mhm.
What is kind of the one thing that you would say would be to a therapist to say, here's how you would justify caring for someone like me after the experience that I had?
I mean, to me, it's just like those other patients are most likely going home and only having to take care of themselves. But we can't forget that this woman also has to take care of a baby. So, yeah, she may be like high functioning, in air quotes, like being able to walk back and forth, but this doesn't even include any of the things that she's about to to undergo, especially if she's a new mom. Um, because breastfeeding was extremely taxing for me. Um, I was so tired that it was very difficult for me to even make food. But on top of that, me being like a natural like ectomorph, so very tall and slim, like I have to eat or I will just keep getting skinnier and skinnier. And so on top of that, knowing that with breastfeeding, I was always told by like other people who were breastfeeding, they were like, make sure you eat because if you don't, you're going to be really, really, really drained. So I would say to this population or to the people who are kind of, I guess, hesitant to have PT and OT, I would just say, okay, well, I see that you like walked with the person, but have you done any other tasks that would exert them to the point that they're going to be exerted once they go home? Like that would be the biggest thing because I also think that when you point out certain things to especially to the nurses. For instance, in one instance, I had one nurse, love him to death. He's actually a genius. He's literally on every floor because he's that good. Like he can be anywhere at any point at any time. And he was just like, well, that patient's up and walking. They're fine. And I'm just like, I was like, gently was just like, you do know that PTs and OTs do more than just take people for a walk. Like patients aren't pets. We're not just taking them for a walk. We're actually assessing their vitals with activity. We're actually determining what their endurance level is. We're actually seeing if they are functional and safe. Um, And we're checking back in with the patient to see how they feel. Do they feel confident? Because a lot of the times, there are some people, there are going to be lots of moms who probably are just going to say, yeah, I'm fine. I'm fine. I'm fine.
Exactly.
Which I had a patient who was just like, I'm good. I'm good. And I literally told the OT, I was like, she's lying to me. I want you to ask her how she's doing. She ended up
Wait, you said
breaking
that to the
down
who?
to the OT because I
You
was
have an
able to get,
OT on your team now.
hmm yeah, yes. We have a new travel OT, and the other OT who's also perm, she was hesitant to about it, but when I further explained where I was just like, Elizabeth, you worked in cancer with cancer patients. So I was like, you're all about energy conservation. You would be great with these moms. And so once I fully explained everything to her, she was like, oh, okay, this seems pretty good.
Okay,
Okay.
Keisha, hold that thought. I want to bring
Okay,
up an
holding.
OT. I'm going to bring up the OT I've been talking about. If I can find her, Marley, if you could turn on your camera, I'm going to actually bring you up because I want you to talk to Marley the way that you talk to your OT, Keisha, right now. We're going to actually role play this now. People have told me in my courses, like, I hate being, in the role plays, but I think Marley, you're good to go. So Keisha, talk to Marley like she's the OT.
Okay. So basically, you're needed. As an OT, we already know, I know what OTs do. Y'all are all about activities of daily living. As a mom, we now have new activities of daily living that we have to now try to time in and think about as far as like our think about what the things that we need to do. As a mom, you especially if you already have other children, usually we're already the person who's making the food for the family. So there's one activity that you will have less energy for. You're usually changing diapers, you're breastfeeding, you're up all the time. And if you are like me and slightly OCD when it comes to certain things, then there's cleaning. So it's also those tasks. These are all ADLs. Mom duties are ADLs. OTs are needed. There's also, I feel like OTs learn more about the mental health component than PTs do. And as a mom who has had postpartum depression, y'all are needed like big time. I feel like OTs are really good at breaking down tasks to where someone won't feel so overwhelmed. And that is definitely needed in this mom population. Energy conservation, obviously, with showering, we already know that that's a crap ton of meds compared to just, walking. It's more meds
Mhm.
than it is just for walking.
And
These are
Mets
the things,
are,
uh, isn't it that the energy
yep,
I forgot
yep,
what the yeah.
metabolic equivalency of tasks. All right, so Keisha,
Mhm.
give me a second with Marley. Marley, as a level one trauma center OT, you are pulled in every direction all over the hospital. You come into a room and a mom is already up and walking, right? She looks like Keisha, who's 6'1", right? Athlete, like she had a grade 2 tear. She doesn't have acute respiratory distress syndrome. She doesn't have preeclampsia. She really does look fine. Is this not evidence-based practice? You at least do a what? Low complex eval and just see if you can sign off and say she's fine. But do you just look at her and then just walk out the room? Like, is that evidence-based practice or is an eval evidence-based practice? I really want to know.
Sorry, my button stopped working and my dog just joined, so she pops in. Sorry. Um, yeah, so for my hospital, I automatically get an order for all of anyone who gives birth now. So I am already going in and doing at minimum low complexity screens for everyone or low complexity evals at the bare minimum. So yeah, so for when I walk in the room, if they're already up, they're already moving, like I generally just ask them like, how do you feel? Like, how are you feeling right now? Um, and that varies, like, oh yeah, I feel great. I've been walking to the bathroom, I've doing all the things, everything's fine. And then I start to just break it down task by task. So okay, so have you showered? Yes. How did that feel? Did you need to sit down when you did that? Because if you did, I would recommend you get a shower chair when you go home, right? If you didn't feel like you needed to sit down today, then just keep an eye on how you feel when you do that when you get home. We have walk-in showers here. If you feel like stepping over a tub is going to be a problem, I would also recommend a shower chair, and then talk about like a tub transfer. Okay, so we've gone over showering. Oh, and do you need a long-handled sponge? Because I have those too. Was it difficult for you to bend over while you're showering if you have or haven't done that yet? And I go into using the bathroom. How are you doing with using the peri bottle whenever you have peed? And is that going well? Is it not? Have you had a bowel movement yet? Are you able to reach behind and get yourself cleaned up? If not, I got a bottom buddy right here for you. Um, and so then we talk about that. If they're already dressed, how did it go? Are you having trouble bending over to put your underwear on? I would suggest sitting down the first couple of times when you do that. Hi, Lucy. I know it's so exciting. This is Lucy.
Hi, Lucy. Is it Lucy? Hi,
Yeah.
Lucy.
Um, so yeah, and I tell them like I would suggest just sitting down. It's hard to get your balance when your belly is trying to shrink back down and you've just done all the things. Do you need a reacher? Lucy, I know, I'm sorry.
A reacher,
Um,
right? Exactly. Exactly.
yeah,
Even
do
not,
you,
even for people who didn't have a C-section, even who are just postpartum hemorrhage, if they're getting dizzy, just reaching, right?
yeah.
And reaching down, a reacher is golden.
Yeah, the reacher, the long-handled sponge, and the bottom buddy are typically what I give people if they're having trouble. So long story short, if they are up and moving around and doing the things, I start to break it down ADL by ADL and then talk about like how we can break that down even further, and then talking about newborn care tasks. So like, all right, so if you're going to be bending over a sink, doing sink baths for a while, remind yourself to stand back up so you're not crunched over all the time. Have a caregiver or whoever's going to be home with you maybe put the car seat up a little bit on a higher surface so you don't have to bend down as far to do that. Talking about abdominal protection techniques for self and newborn care. I mean, the list goes on and on.
It
I've
sounds like more than a
made
low
my
complex
spiel.
eval. I mean, you're going out into all
Yeah,
the
just me
treatment,
talk.
right?
Yeah,
Yeah. So billing,
yeah.
Erin Licati,
Um,
I want to pull her up. Erin, if you're on, please put your camera on. I want to pull her up to kind of round out this conversation because both of you work in acute care. Erin has done trainings kind of outpatient with doula communities of doulas. I want to ask you, Marley, and I want to ask you, Dr. Bradford, both of you, if a person wanted to bring their services in the hospital, they don't work for the hospital, would they be at a great disadvantage because they don't have access to the chart to see how much that blood loss that person had, what their hemoglobin drop was, right? Someone who looks like Keshia, who looks fine, she's walking around moving. If they're outside of the hospital, they don't have access to the lab values and everything that you do. How can they best prepare to treat this patient population that in a lot of hospitals, they're still blocking rehab services? We just know that that's going to be an issue. So we have to figure out different pathways to get rehab therapists in the room, whether it's video, virtual care, whatever, or whether they're doing what doulas are doing, offering their services as private pay. How do we get them up to the level of knowledge of what you would cover in an acute postpartum visit so that they're safe with people, so that they're not doing too much? What do they need to know? Keshia, speak from a PT standpoint. Marley, speak from an OT standpoint. And Dr. Licati, please, I'm going to bring you up just to kind of round out this conversation on what people need to know to treat this population. Keshia, you go first.
Well, I mean, vitals as far as like blood pressure, that's something that you can kind of go off of. That in kind of to backtrack, I recently did like a spiel for PT and OT to a group of moms who were there for just a pregnancy, like one-on-one class, just to kind of like so that they were more aware of what can happen. And that nurse who runs it allowed me to at least kind of like let these patients know that, hey, when you deliver, if you are struggling or if you're not struggling, you can ask for PT and OT. And these are the things that we're going to do. And one of the things that even the RN didn't even know that PTs and OT do is that we, assess vitals with activity, because most of them just check the blood pressure when they're in supine. They're not checking it before and after activity. They're not checking how their oxygen like saturation is looking with walking or with stairs and all of these things. So these are things that even if we don't have access to like seeing the hemoglobin levels, we can at least access that and do that ourselves, because there will be a blood pressure machine somewhere around there.
In the acute care setting, you can.
Mm-hmm.
But Marley, for someone who's an outpatient therapist, they want to start these, these services for this inpatient acute population. What do they need to know in terms of doing that?
Yeah, for someone coming from outpatient, I honestly think the biggest thing that I like, just what I tell people in general, like the best thing that you can know is just how to protect your abdomen and learning about diaphragmatic breathing, how to take the pressure off of your belly, how to take the weight off of the areas that we are trying to heal. So when you think about those two components, how are we able to do our self-care and our newborn ADLs? So, and then given the activity restriction of at my hospital, they tell everyone vaginal or C-section, you have an 8 to 10 pound lifting restriction. So how for 6 weeks. So how are you able to do those things with an 8 to 10 pound lifting restriction? But then I also tell them life is life as well. Like I understand that is a recommendation, but I understand that life is life. So how can we teach you to function and take care of your 2-year-old as well? So I think just thinking a little bit deeper about like the basic body mechanics, if you don't have access to lab values and what their vitals were in the hospital setting, and just having a general understanding of how the postpartum body functions differently than a non-pregnant and postpartum body.
Perfect. Thank you both. Aaron, please bring it home. Thank you both. I
Yeah.
really, Aaron, I want to spotlight you just for a second because you taught. I was able to actually see all 4 hours last year when you taught, and I was just like, okay, I was blown away. Like, yes, this was a basic course for occupational physical therapists. I would even say this was a basic course for those individuals who don't have access to this population as an acute care therapist. And so you were talking to acute care OTs and PTs, but your course was actually that much more relevant for anyone treating this population acutely. There's a difference. It's a difference between an acute care therapist and someone treating this population acutely. And basic education that you would want someone to know who wants to start a program, either if they work outside the hospital like I do now, trying to get in, or they're in the hospital as a therapist, what would you cover?
Perfect.
What's your name, sir?
I have somebody with me. So who really
Yes,
wants to
you
know?
starred on our last episode.
Yes, he's very excited to be here.
Thank you for
So-
joining.
Yep. So, as far as not having access to lab values, I would just tell somebody to think about what symptoms somebody would have if they had something going wrong with their labs. Because that's really what we care about in the hospital. I mean, why do we care that your H&H is low, your hemoglobin and hematocrit is low? Well, we care about what that's going to mean for your system being able to compensate and handle activity, right? So in an outpatient setting where you might not have labs, you can still watch somebody for paleness, like Dr. Bradford said, their vitals, right? Like tachycardia. You can monitor them for shortness of breath, right? All the kind of symptoms that you can get with having your hemoglobin be really low. Or if you have preeclampsia and your liver labs are getting bad. Well, there are symptoms that can go along with that, right? Like itching in your legs or changes in your urine. That those are things as an outpatient you can be monitoring for and asking about, even if you're never going to see a lab value. So I would encourage someone who's going to see people outside the hospital or even a PT in the hospital. Not everybody has all these labs done on them, right? Like you can watch for symptoms that indicate the labs are going in the wrong direction and let that inform your treatment approach. I also had a question for Marley. If I can ask her a question.
Oh, absolutely. Marley, are you still with us?
Yeah, is it the one you asked in the chat? I accidentally just replied privately back to Rebecca.
Oops.
Oh, yes, that is my question. That is my question. I've had therapists that
I'm looking for you, Marley.
don't want to go see this population because they feel like it, because they're walkie-talkies, like Rebecca said,
Mhm.
they feel like that makes them therefore a low complexity eval. And at least in my hospital system, you don't get as many productivity points for a low complexity eval as you do for a medium or a high complexity eval. So they feel like they're harming their own productivity numbers, which our manager really cares about if they have to go see too many of these people. So I made the argument that, like, I don't think they're low complexity. Just because they're walkie-talkie doesn't mean they're low complexity. But I'm a PT, so I don't know if how you decide the complexity levels is different for OTs versus PTs.
Yeah, so I will just start off by saying that I think I am extremely lucky in the place that I work because I work for a nonprofit hospital. So honestly, like insurance and billing is not like a huge thing. Like it's not a huge hurdle for me. I'm very lucky in that aspect. And my productivity is based upon the number of patients that I see a day. So I work nine
Oh, that's
hours a
nice.
day. Yeah, so I work 9 hours a day, so my productivity is supposed to be I'm supposed to be seeing 10 patients a day. And they're not very strict about like if I mean honestly, if I spent 8 minutes with all 10 of them, they would not know and they know, but like
Wow.
they don't really care.
Keisha, what are you? Are
I'm not
you on
saying yeah.
That's crazy, Marley.
Right?
10 patients and you can
Right.
see them for 8-minute evals.
I
Yeah.
mean, I'm not saying it's a great system. I'm just saying I am it's very chill where I work. Should it be that way? Probably not. But so therefore, I can't say I have a lot of experience in like getting pushback from that. However, for when I bill, if they are just laying in bed or sitting in a chair and not moving at all, and all I'm doing is talking to them, my spiel is about like 10 minutes, then I bill it as low complexity. But if they do any sort of movement or ADL, in conjunction with the education that I'm providing with them, I usually bill it moderate
So
complexity.
you don't build complexity on their like what their birth course was or what their comorbidities were. Like if they have gestational diabetes and they're also just sitting up and talking to you, or if they lost a significant amount of blood, it doesn't raise your complexity level of your eval.
Not necessarily for me. I usually base it on like functional performance is what I try to
During
base
the
it off
eval,
of.
their functional performance. Interesting.
Yeah.
Okay. And
Mhm.
Dr. Bradford, I was wondering the same. Do you work for a nonprofit or a for-profit?
For profit.
For-profit. Does it
Yeah.
change?
I would say so she's lenient in the fact that she's just like, it'd be great if everyone can get at least 16 units in their 8-hour shift.
Hmm.
And so I don't know, to me that's semi-reasonable, but she also was just like, if we get 10 to 12, she's like, then you're doing good. But if you can get 16, I'd be happier. But she's more so looking at it because of other like rehab techs so that they're essentially like paid for. That's why she would like for us to have 16 so that she can vouch so that they can still have a job. But yeah, as long as it's more than 10, then she's a-okay.
The things that outpatient therapists don't have to worry about. I mean, of course, outpatient billing therapists. I'm not talking about you guys. I'm talking about your virtual health, your kind of these innovators that we're kind of hearing more of who want to start businesses and bring their services into a hospital they don't work for. As acute care therapists by background, what's your kind of final say on that? Do you think that that is a viable model in the future, Aaron?
As far as I know, I don't think there's any reason why PTs and OTs couldn't, like, the patient couldn't hire you like they hire a doula, right? To be a support person that comes with them to the hospital. Like, I don't think there's any like legal reasons you couldn't do that. Um, right? You would just have to make those connections with people in your community, right? And partnering with something like a doula or midwife organization might be a way to do that, right? Because those are already people that are used to using that kind of model, right? To get into hospitals that they aren't actually employed by. I mean, I don't see any reason why we couldn't do that too.
Marley, what do you think in terms of OT? And practice, OT practice. So that's why I really value your kind of thinking on this. Direct access is not the same for OTs across the states. So, but there are some states with direct access. So where do you see the future of that being?
Yeah, so I think so I was just at the AOTA conference last week where I was lucky enough to get to hug you and see you in person. Um, and there was so much stuff about maternal health there, and it was just like it was awesome just to see like the number of people that are talking about it and getting involved. There is still there's a lot of research out there and a lot of people saying, yes, OT needs to be involved in the maternal health setting, in the hospital setting, it needs to happen. However, there's not a lot of people, they're still trying to figure out how to do it, right? So, trying to figure out how to get access to these courses that you've built and created. Um, so, I think there's a huge opportunity. I think we just need to continue to like advocate. OT in itself, in my opinion, is a very underserved area because people we're just kind of like the unicorns of rehab. I feel like no one really knows what we do, including ourselves, to be completely honest with you. Like I'm like, there's really not a true definition for OT. There's really not. Um, so
I
I
think you
think
guys
just
know, you just don't give yourselves the credit. Do you remember that coda in the audience who was like, hey, what would I do as a coda? And then I just like put the mic back on her. I was like, you tell me. Like, I'm not gonna be the professional that tells y'all what you do. And she slayed it like a coda
yeah,
student. She was a student who was a coda. And she said, well, we would do this. And I was just like, okay, like what's stopping you from getting out there?
yeah, absolutely. So yeah, I do think there's definitely it's getting bigger and I'm so excited about, the role that we're playing in across all settings. There was a oh shoot, what is her name? Dr. Khan. I can't remember her first name, but
Sabina
she
Khan.
yes, oh
She
my
is a
god, she's
force. Oh, I would have loved to meet her. Tell me about her.
oh, she was amazing. She did a hour-long short course on the role of OT from family planning all the way up to 1 year postpartum and all the steps in between 9 months of pregnancy in the hospital setting, 6 weeks after, and 1 year after, and it was just, like, mind-blowing. Um,
Okay. So Dr.
so
Sabina Khan,
yes.
I'm following her publications. She is writing all the time. She's putting literature out there. She's seeing moms. She did a home visit with a teen mom. I mean, she's like on the boots, like boots on the ground, exactly what I'm talking about. Like I asked in the chat, what do you all think about this future of occupational and physical therapists being the direct to consumer provider, getting out there and reaching people directly, not waiting for hospitals to give us permission, because we know that there are far more hospitals not providing OT and PT services on the maternity unit than there are that do, that you work in. So, Dr. Bradford, what do you think about this?
I think it's exciting, especially to just know, like, Marley, it's an automatic order. I'm trying to get on that level. Like,
Marley's on a different level.
I still have to just, prance around and labor and delivery and be like, hey, so I hear a baby. I'm here. Hi. and
And I should say, Dr. Sizzler, like you did your capstone on this. Is that right? Like it started as a capstone and then you created I actually watched your pitch. And so is that right? Like I watched you actually pitch to your hospital system. I was joining in through Teams or Zoom, and I actually watched you present to a room full of your colleagues, and I was like, this is next level. You invited me to your pitch, to your hospital pitch. Um, I mean, telling you, Keisha, it just gave me
I just got to
goosebumps.
clap
So,
for
like,
her
yes,
because
yes, absolutely. So, I mean, I want to give people kind of the lay of the land of what you all are doing. You're in the hospital. And it seems like you're open to pushing the boundaries. That's all we can do. We don't have evidence yet. That's just clear. We don't even have a case study, Marley. We don't even have one case study of a person's experience with OT after birth, like after a primary C-section or after a third-degree tear. We have not one case study, which is considered the lowest level evidence. And so this is more of my pitch to whoever watches this is to continue to push the boundaries, but all of us are going to have to come up with some type of framework that we can research. And so my final kind of pitch to the audience who's here is if you had a checklist, if you had something that was just cut and dry, here are the things that you would evaluate with anyone, someone after a C-section, after a perineal tear. Is that something that's going to be helpful for you? And I say this because Marley just actually put in something in our ERAD Facebook group, in our Enhanced Recovery After Delivery Facebook group, that I wanted to close out with tonight. She put in a question on, well, what do you do if a person is high level and they're not getting out of bed? You know, they have the education, but you're not actually able to see them functionally perform. Well, Marley, if I teamed up with you and I teamed up with Dr. Bradford and I teamed up with Dr. Locati on a checklist, and that person was given a checklist almost as a functional screen, as a way to communicate to the patient as well. Here's what we want to check to make sure you don't have any surprises when you go home. You have no surprises. It's almost like including them in the eval to make them understand you are there for their physical function, right? Their mental function, which is kind of underlying. You're not going to maybe say that because you don't want to kind of spook people, but if they just know this is a checklist, I want to see you do A, B, and C, do you think that would get the buy-in that you need?
Yeah, I think if maybe I, like you said, like I have like even just like a physical handout of just like like an actual checklist of being like, your doctors want me to evaluate this and make sure you're doing okay. Because I do start, like I walk in the room, I say, hi, my name's Marley, I'm with OT. It's my job to get to know you, see how you're doing, moving around, taking care of yourself. And we'll get up and do some things and I'll give you some feedback and we'll see how everything feels and we'll talk about it along the way. And then if it starts with the education, sometimes by the end, they're like, oh, I'm really tired. I really don't feel like getting up, or I've been moving around and I feel okay. Um, but I think if I broke it down step by step, like, okay, we want to see how you get out of bed and we want to see how you are doing the things. I feel like that could be successful for.
Dr.
And
Bradford, from
thank
a
you.
PT standpoint?
I mean, I agree everything with what she said. I
Yeah.
mean, that was literally my pitch whenever I presented in the pregnancy like 101 class, was just like, this is what PT does, this is what OT does. We are here for you. And that's what I just kept reiterating. I was just like there, and I even just flat out said it. I was like, most people are going to be so cooped up and just focused on your baby. No,
Mhm.
your baby's cute, but I don't care about your baby. I care
But
about
you're
you.
here for mom.
Yeah,
Right.
I was just like, I care for you. I care about you. I don't care about your baby.
Awesome.
I hope the baby's great, but I really just want you to feel like you are good. And especially again, just being in that space and knowing what it feels like as a first time mom and kind of feeling like lost initially. And then just almost like, it was almost like I had to like figure it out type of thing.
Mhm.
It just, I just wanted to reiterate, like, if anybody cares, I care. Like, I will be your support system. I know what it's like. I know what you're feeling. I know how you feel, and it's okay to feel that way. So
Right.
I don't know. I got good feedback from it. So we'll just see if, in the next like month when those babies pop out, if I actually see any of the ladies who were in that class.
Awesome. Well, I'll follow up with you both. This has been great. Thank you so much for allowing me to pull you up. Definitely, Marley, this was unexpected, but I was really hoping that you'd be here tonight. And then Dr. Bradford, I mean, always, like, it's always a pleasure to see you. So thank you both, really. And so, Aaron, if you're still here, I'd like you to kind of just close out with anything that you are teaching in the next little bit. I know that you have a course that I would really like people just to know what they're going to be getting, and if also it could be potentially open to those therapists who don't work in the hospital, if they can actually be seeing people acutely with the information you teach.
I have two classes coming up in the next few months. On April 20th, I'm teaching the introduction to acute postpartum PT and OT again, that I taught with Pelvic Health Network last year, and it did really well. And then I also added a new course through the Pelvic Health Network on seeing acute antepartum. So those are people who have high risk pregnancies with complications and are admitted to the hospital for some amount of time. And that's going to be on June 1st. Both of them are going to be live virtual classes, but the replays will also be available for people who can't attend live or who want to rewatch them later. So in the postpartum class, it is geared towards acute care therapists. And I would say, yes, people who are going to work with patients probably in the first maybe 6 weeks or so postpartum, even if they're not in the hospital, could benefit from taking it. Like I said earlier, when we talked about lab values, for example, I go over things like symptoms you should really be looking out for that would be valuable information, even if you didn't have access to a chart that you can review in the hospital like an acute care therapist did. But we'll go over the basic 101 physiology of pregnancy and childbirth because it's geared towards therapists who maybe aren't pelvic PTs or OTs themselves, but find themselves getting orders and being sent to this unit. And then we'll go over kind of what to look for in somebody's chart, what kind of complications that are unique to this population you might run into, and what you should be screening for, and how to kind of develop an initial home exercise program for people. I've also really beefed up the perinatal mental health section compared to last year when I taught this course. So that's a little more in depth than it was before. And we've added some extra case studies, like for specific patients to it. And then for the antepartum course, the high risk pregnancy course, it'll talk a little bit about the basics of kind of physiologic pregnancy without complications, in case people haven't taken the first course. But most of the course will be devoted to going over the most common pregnancy complications for which people get admitted to the hospital, what kind of activity restrictions they're given, how you as a therapist can determine what is safe or not safe for them to do with their body, and how you can still provide exercise, manual therapy, mental health support, coping strategies, family planning and involvement, right, for what's lying ahead for them, and also just prepare them for birth and postpartum, right, knowing that they've been deconditioned on bed rest probably
Yeah,
for an extended period of
absolutely.
time.
Excellent.
Mhm.
I appreciate you going through that because I think that you also added in handouts for in both Spanish and English. Is that right? Cesarean section handouts. I thought I saw something
Yes.
with that, but I was
Mhm.
just like, this is huge. This is basically every resource that someone um, could need just in a pinch, right? Or, just to get started and just to really get comfortable treating this patient population or even giving those handouts to providers. Be the vehicle, right? You're
Mhm.
creating a vehicle, which is the handout. And those are really hard to just get approved in hospital systems because they're really like, some of them it's just not like an easy, oh, I want to give
Mhm.
this to every patient. Like it has to be screened. So if you already have something in Spanish, that's huge. The providers already are being exposed to OT and PT through a handout before they actually see you at work. And so
Mhm.
this course, when is it?
So the postpartum is going to be April 20th, and the antepartum is going to be June 1st. And you can sign up for both of them on the Pelvic Health Network site. I also made a post about it in the ERAD group on Facebook, and
Awesome.
the OBPT and OT group as well, so people can see the link. And yes, I have a Spanish handout that actually an OT made for me, a local pelvic OT who speaks
Yes.
Spanish. She did the Spanish handout for me.
Awesome. All right.
So
So collaborated with an OT
mhm,
and PT.
mhm,
And so a lot of people will ask, well, wait, what about your course? What about the perinatal health specialist? That is going to split into two cohorts. So I spent 3 years, like I said, really focusing on acute care therapists. I'm looking for therapists like Aaron Blacati to be creating more courses and training for acute care therapists who don't need a big certification and also who may not have a need for all the in-depth education that we provide under the certification. We go into critical care and emergency department that you might see this patient population. We're meeting monthly like this, kind of in these forums to discuss cases or case scenarios or different barriers that you might have. If you need something that just gets you in the door, please look at Dr. Lakati's course. I'm incredibly grateful and relieved that she's actually creating content because not one person needs to be doing this. Our biggest competition is ignorance right now. If you still are getting questions about what does an OT do, that's a problem. It's 2024. Like, let's get up to speed. as to general OT practice and general PT practice, and then we can introduce all these specialty areas on the maternity unit. But we have to be at the table to have the conversation. So Dr. Locati's course is dropping in April. Sign up now because my course is actually going to take a very, very different turn. So the cohort that we really are just graduating now through, that's taking the exam that ends in May, it's going to be a shift come June. So I'm going to focus on those therapists who want to provide virtual care or in-person mobile care. So I'm really sinking a lot into a virtual mobile practice type cohort. So there's going to be 2 testing periods of year. The first testing periods are going to be really geared towards the content that the acute care therapists who work in the hospital received. And then the second cohort is going to be geared towards those business owners who want to create a business and increase their revenue and create programs in hospitals they don't work for, but that are embedded in their communities. And so we're going to start a business aspect to the course in June. And so you're going to see a big difference in terms of the pricing, in terms of the traditional style of teaching. There's going to be a lot more interactive courses under the perinatal health specialist certification, enhanced recovery after delivery. But a course like Erin Locati, I've been really supportive of her kind of like branching out and standing on her own. And so I'm really just kind of pushing her to really get this education out there. And so in terms of CEU support, you might actually be seeing a lot more of that. We're really working on Texas because it's its own country. And I really want her to really spread this knowledge all throughout because there's so many maternity centers there where individuals can really benefit from this information. So please, Pelvic Health Network, courses.pelvichealthnetwork.org/Erin Locati. You'll be able to see her 2 courses that are going to be released in April and in June. I'm totally excited about it. Erin, any last words on just the topic of the evening? What do people need to know to start a rehab program in the maternity hospital?
I think really like that you're capable of doing it, right? I mean, any PT or OT is capable of really making a difference in these people's lives. Like whether you have pelvic training or not, you have knowledge that you probably take for granted every day that is just so far above what the average health literacy is for a lot of people in your community. And just sharing even a fraction of that with some of your patients could make a big difference, right? What you know about abdominal surgery with a C-section patient could be the difference between them like feeling like they're going to die going up the stairs and them being able to actually manage that at home and in a way that saves them a lot of pain.
Yeah,
So
it
yeah,
saves
that's
their
what I would tell
lives.
people is
Yeah,
that you totally have something to offer and you can totally do it. You just have to start. You just have
yeah.
to do the thing.
Do the thing. Erin, thank you so much. I can't thank you enough. And absolutely, I will open it up to questions and thank you all for joining tonight and with us. I always like to stay on a little bit longer after this ends. So thank you all for your time.